Hey guys, so this is the lecture portion of the activity that we're going to have you complete for the ECG lab. All right, basically what we're going to go over are the basic principles of heart contraction, how the heart contraction relates to ECG. We're going to go over limb leads and chest leads, and we're going to go over how to read the ECG paper. And then after that, we're going to talk about heart rate. So I'll show you 3 different methods on how to determine heart rate. And then we're going to go over rhythm. With rhythm, we're going to talk about irregular rhythm, including bradycardia, tachycardia, sinus arrhythmias, heart blocks. And then lastly, we're going to talk about infarction. Starting off the contraction of the heart, myocytes are polarized or negative at rest and become depolarized or positive as the muscle contracts. This contraction begins at the atria, as you can see here in this second picture, and it sends this wave down through the rest of the heart. As the heart muscle depolarizes, becomes more positive, the deflection recorded on the EKG will be more positive as well. So heart muscle becomes more positive down here. This is the electrode. And then on the EKG sheet, it will become positive or will go upwards. Over here on this side, you can see the depolarization on the ECG represented, and here the repolarization. So depolarizations will be usually a sharp triangle looking shape on the ECG, while repolarization will be this little hill, this little hump right here. The unique thing about hearts is that the heart does not need an external stimulus to produce its own contraction. The heart muscle has a cluster of cells within itself, several clusters of cells within itself, that determines the pace of the heart. One of them, the main one including, is the SA node. The SA node is the main pacemaker of the heart. While there are other pacemakers of the heart, they are kind of like backups. They're there just in case the SA node fails. But the SA node, its pace is 60 to 100. So the normal range of beats per minute is 60 to 100 beats per minute. The SA node initiates the depolarization of the rest of the heart. As you can see, the depolarization will start here and then go out, spread out to the rest of the heart. As the depolarization moves down the heart, the atria will contract, and then here you can see the ventricles will contract. The atria will contract downwards into the ventricles, and the ventricles will contract upwards into the arteries, creating this QRS wave on the ECG. As you can see here, deoxygenated blood flows into the atria. The atria depolarizes, contracts, and pushes the deoxygenated blood into the ventricle, into the right ventricle. The right ventricle will then depolarize and contract into the pulmonary artery, which will take the deoxygenated blood into the lungs. And then over here, the reoxygenated blood will come into the atria right here. Atria will depolarize and contract, push the blood into the ventricle, the left ventricle, and the left ventricle will depolarize and contract, and then push the blood out to the rest of the body. So as you can see here, this is part of an EKG cycle, of a heart cycle. We are missing the P wave right here, but this is basically a look into the ventricles. So right here, the QRS is the depolarization of the ventricles, which is the contraction of the ventricles to push the blood out. And then right here is ventricle repolarization, which is the relaxation of the muscle. Here's the full picture: the atrial depolarization, ventricle depolarization, and then the ventricle repolarization. can be illustrated by these two pictures. Now we're going to get into limb leads and chest leads. This is what they look like on an EKG strip. We don't need you to know the intricate details and the differences between all of them on the EKG strip, but I'm going to show you what they are and what they represent. For the methods of your ECG lab, you should already know how to place ECG stickers, ECG electrodes. So this is going to be like a review for you. I'm going to go over it again just as a refresher. Right here you can see the placement of the limb leads, the right arm lead, the left arm lead, the right leg lead, and the left leg lead. And then over here you can see the chest leads. The chest leads are V1 and V2 on either side of the sternum, between the 4th and 5th rib. V4 down here is between the 5th and the 6th rib. V3 is placed diagonally in between V2 and V4. V5 follows the same intercostal space as V4 at the mid-clavicular line up here. And then over here you can see a better picture of V6. V6 is in the same intercostal space as V4 and V5 because the ribs kind of move upward in this direction. And it is in the midpoint underneath the arm. Now these look weird and complicated right now, but don't worry, in a few slides it'll make more sense. These are the leads that originate from the limb leads 1, 2, and 3, and they can be represented as these 3 lines. 1 is looking at the heart through a horizontal direction, and then 2 and 3 are kind of looking at it from a diagonal direction. AVL is looking at a mirrored diagonal direction as AVR, and then AVF is looking at a upwards vertical direction. And kind of these are what they look like all together. This looks like weird and still like complicated, but the next slide will explain it a little bit better. This is basically what these leads are looking at. These are what they mean. These leads are looking at the heart from different directions. So AVR and AVL, those diagonal leads, they're looking at it from mirrored directions, but on either side of the heart. Lead 1 is looking at the heart from a horizontal view from the left side. And then 2 and 3 are also mirrored, and AVF is looking from upwards from the bottom portion of the heart. This is a picture explaining the chest leads. So the chest leads are basically doing the same thing, but they're looking from different angles across horizontally from the heart. And it makes sense because of where they're placed. V1, V2, V3, V4, V5, all across. V1, V2, V4, V3, V5, V6. Now I'm going to get into how to read the paper itself. So you've probably seen EKG paper before, but if you haven't, it basically looks like this right here. A bunch of big squares with little squares inside of it. Each big square has 5 little squares inside, and each of the little squares are 1 millimeter by 1 millimeter. Each big square is 0.2 seconds long, kind of like a graph. EKG strips, their x-axes are time. So each one of these big squares is 0.2 seconds long, and each one of these little squares are 0.04 seconds long. This will be really important when you analyze your EKG strips. This is a picture of one of my EKGs that I took apparently at 4 in the morning while I was at work when I worked for West Virginia University Hospital at Ruby Memorial Hospital. I was an ECG technician, and me and a couple of my other coworkers, I think we had an exam coming up, and so we were trying to determine if we were having heart attacks. It was particularly slow that night, so we performed EKGs on ourselves. Anyway, we're going to get into determining heart rate through EKG strips. There are three different methods. I'm going to talk to you about the triplets method, the 6-second method, and the R to R method. The triplets method and the R to R method are methods you should only use for regular rhythms. I'll get into regular rhythms later, but keep that in mind. Triplets and R to R, only regular rhythms. The triplets method is fairly easy. You start at the R part of the QRS wave. You start preferably at one of these waves that start at the beginning of one of the big squares. So one of the big squares would start at the tip of the wave, and then you count down. Each big square is one of these numbers. One big square would be 300, the second big square would be 150, the third big square would be 100, and then like this one, it's between, this R wave is in between 175. It's in between this square. So the rate would be between 75 and 100. And if you go over here, it would most likely be between 68 and 65. Each one of these little notches are one of these smaller squares, but it's easier just to memorize 300, 150, 100, 75, 60, and 50. Here's another example. With this, you start with one that's close to or on top of the start of a big square, and then you count. So one big square, 300, two big square, 150, three big square, 100, and then that one's between 100 and 75. So this little square is 94, and then the next little square is 88, and then the next little square is 83, and then the R wave is in between 88 and 83, so we'll just say this heart rate is between 88 and 83 beats per minute. The second method, the 6-second method, is a method that you can use for irregular rhythms. It is the only method that I'm going to show you that you can use for irregular rhythms. So basically what it is these little notches in the EKG strip are 3 seconds. So this notch to this notch is 3 seconds, and then this notch to this notch is 3 seconds. So two of these gaps, two of these chunks are 6 seconds. And basically what you're going to do is count how many cycles, how many PQRSTs are in this 6-second section right here. And once you have your number, so 1, 2, 3, there are 3 cycles within this 6-second strip. So 3 times 10 is 30 beats per minute. And this person definitely has bradycardia. It is well under the 60 beats per minute. This person needs help. The last method I'm going to show you is called the R to R method. This one is a little bit more mathy. The 6-second method is a little bit mathy, but this one, the R to R method, you have 2 steps to go through. Basically, you're going to take the number of small boxes, multiply that by 0.04, and then you're going to take that number and have 60 divided by that number, whichever number that you found, and then that's going to be your heart rate. So for this strip in particular, you're going to start probably with this one since it's the closest one to the beginning of a big square. And each big square has 5 small boxes. So 5, 10, 15, 16, 17, 18, 19. So 19 times 0.04, you get 0.76. 60 divided by 0.76, 79 beats per minute. This is only for regular rhythms. So now I'm going to get into rhythm. You're going to know what a regular rhythm, what a normal rhythm is, and what an irregular rhythm is. Normal sinus rhythm is between 60 and 100 beats per minute, and that there are equal distances between the waves. Sometimes you can have a heart rate between 60 and 100 beats per minute, but the waves may differ in length between. So you can pretend that pretend that this is 60 beats per minute. So say that you had 2 QRS waves right here, and then a space, and then regular QRS waves, and then you had another 2 right here, and a space. Basically, anything that doesn't look consistent, like this. Like this would be very consistent. Anything not consistent would not be normal sinus rhythm. Sinus bradycardia is anything below 60 beats per minute, and sinus tachycardia is anything above 100 beats per minute. Sometimes it's hard to tell if the waves are equal distances, but you can use a ruler sometimes, or you can make notches on a piece of paper and then make a notch here, like pretend you have a piece of paper right here, you make a notch here on the paper, and then you make a notch here on the paper, and then you move that paper to compare to see if the notches are the same length between each one of these R waves. And that can help you determine whether or not it would be a normal sinus rhythm. This rhythm is definitely sinus bradycardia, but we can use our methods of determining heart rate. So each one of these chunks is 3 seconds, and then these 2 chunks are 6 seconds, and we can count how many cycles. So there's 1, 2, 3, about 4. So 4 cycles in this one ECG 6-second strip, and that would be 40 beats per minute, and that would be bradycardia. This is sinus tachycardia. This is also a 6-second strip, and we can count using our 6-second method. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, about 14, so 140 beats per minute. That is well over the 100 beats per minute, and it is definitely within the tachycardic range. Next, I'm going to talk to you about sinus arrhythmias. There are different categories in sinus arrhythmias. There are irregular rhythms, escape, premature beats, and tachyarrhythmias. I'm going to talk to you about atrial fibrillation, ventricle fibrillation, sinus arrest and sinus block, atrial flutter, and ventricle flutter. Starting off with irregular rhythm, we're going to talk about atrial fibrillation. Atrial fibrillation happens when multiple atrial foci are firing at rapid rates. So foci are basically other pacemakers that can fire at their own rate. They are not the AV node or the SA node or bundle of His or any of those other main pacemakers. They are scattered and they'll pace at their own rate. Atrial fibrillation is when a bunch of these foci are firing at rapid rates and are causing the atria to contract irregularly. You can see it in the EKG strip right here. The P waves are no longer clear, and there are a bunch of waves happening around these QRS waves. So they're causing an erratic atrial rhythm. Similar to atrial fibrillation, ventricular fibrillation is caused by foci firing at rapid rates. These foci can happen anywhere around the ventricles, and they also cause an erratic ventricular rhythm and can be shown on the ECG strip like this. They're no longer defined and regular QRS waves. There's just cluster of waves that are random and erratic. We're going to be talking about sinus arrest. Sinus arrest happens when the SA node completely stops pacemaking. So for whatever reason, the SA node is just sick, it's not working properly, it just stops. And the job is left to the AV node and the other pacemakers to pick up the slack left by the non-functioning SA node. Slightly similar to the sinus arrest, the sinus block, when the SA node stops pacemaking for 1 or 2 beats, but then it starts pacemaking again without the aid of the other foci, without the help of the AV node or the other pacemaker cells. So what's the difference between the sinus arrest and the sinus block on an ECG strip? They're fairly easy to figure out which one is which. Sinus block can be shown with regular R to R intervals up here, and then in equal spacing where another QRS wave would be, and then equal space starts back up again. With sinus arrest, you have that regularity of the R to R, but then where two other QRS waves should be, they're not, similar to the sinus block, but then the QRS wave starts up again at an irregular point. So it should start up here, but it starts here. Similar to determining whether or not a rhythm is regular, you can use the card method or the paper method by making little notches in paper and measuring each of these R to R's to make sure that they are the same length. And then you can use that to determine whether or not it is a sinus block or a sinus arrest. Now I'm going to get into tachyarrhythmias. So the first one is atrial flutter. Atrial flutter is basically back-to-back atrial depolarization without QRS waves. So you can see these little depolarization, these P waves, but no QRS waves following them. The next tachyarrhythmia is ventricle flutter. Ventricle flutter is basically when one foci in the ventricle is firing at rapid rates, and you can see that through these waves right here. And the difference between ventricle flutter and ventricle fibrillation is these waves are very similar to each other, while the ventricle fibrillation, the waves were very erratic, and some were tall, some were short, some were long, the waves were not the same, but these waves are very similar to each other, indicating that it is only one foci that is causing depolarization. Now we're going to get into AV blocks. There are three different kinds of AV blocks: the first degree, second degree, and third degree, and second degree has two subcategories within. A first degree AV block is categorized by a constant PR interval, but the PR interval is prolonged. So a normal PR interval would be 0.2 seconds or less, or 5 small boxes, or 1 big box, or less. But with a prolonged PR interval, it would be longer than 0.2 seconds, or longer than 5 small boxes. This is the main characterization of a first degree AV block. It also is characterized by 1 P wave to each QRS. The first second degree AV block that we're going to talk about is the Wenke-Bach. This AV block is characterized by varied PR waves, varied PR intervals, PR intervals progressively getting longer until QRS is dropped. So you can see here that the PR interval is shorter, and then it starts to get longer, and then here's the P wave, but no QRS wave. It's characterized by a regular atrial rhythm and an irregular ventricle rhythm. So irregular ventricle rhythm, there was no ventricle QRS right here. The second degree AV block that we're going to talk about is the Mobitz. The Mobitz is characterized by a constant PR interval, a normal or prolonged PR interval. It could be either, it doesn't have to be, but it's mainly characterized by 2 or 3 P waves to each QRS wave. So we can see that a 2-to-1, so 2 P waves to 1 QRS wave can be seen up here. 1, 2, QRS, 1, 2, QRS, 1, 2, QRS. A 3-to-1 P wave to QRS wave would be 1, 2, 3, QRS, 1, 2, 3, QRS, 1, 2, 3, QRS. It is also characterized by a regular atrial rhythm and a regular ventricle rhythm. The third degree AV block is characterized by varied PR intervals, and the P waves kind of have a mind of their own with this third degree AV block. They have no consistent relationship to the QRS wave. So sometimes they'll be in T waves, sometimes they'll be in the QRS waves. It doesn't appear that they are constant with the QRS waves. Now we're going to get into blocks. So bundle branch blocks occur when either the right or the left bundle branch have been blocked. So there's a delay in depolarization of the ventricle. One ventricle, let's say that the left ventricle is blocked. the right ventricle will contract, and then the left ventricle will contract after the right ventricle has already contracted. So over here, it'll cause 2 R waves within the QRS. A bundle branch block, as you can see right here, can be determined if the QRS wave is 3 small squares or 0.12 seconds or more. These are visuals as to what a right bundle branch block looks like and a left bundle branch block. A right bundle branch block occurs when 2 R waves can be seen in the right chest leads, so V1 and V2, and a left bundle branch block can be seen when 2 R waves are in the left chest leads, which in V5 and V6. This is further to illustrate what happens with a bundle branch block. So in this case, the left ventricle has been blocked and the right ventricle depolarizes, and then the left ventricle is delayed and depolarizes after the right ventricle, and it causes this double peak right here, these 2 R waves. And this is what it would look like on the EKG, causing a wide QRS wave. This is a review on how to analyze a AV block or a bundle branch block on an EKG strip. AV blocks are determined by a prolonged PR interval or irregular placement or occurrences of P waves, while bundle branch blocks are characterized and determined by wide QRS waves. So now we're going to get into infarction. And infarction basically means that a coronary artery has been completely blocked or occluded, and blood can no longer go down through the rest of that artery. An infarction of the heart can be determined in 3 different ways. An infarction triad is ischemia, injury, and necrosis, and these may not all occur at once to establish the diagnosis of an MI, a myocardial infarction. Today, I'm only going to get into ST elevation and ST depression just for time's sake. ST elevation is a part of injury, and injury basically means that it's acute or recent, so it can either be happening at the moment or it could have recently happened. ST elevation basically indicates that the infarction is acute, that it has happened recently or that it is happening. ST elevation alone can be used to determine if someone is having an MI or not. While ST depression does not necessarily mean that an infarct is happening or has happened, but it does indicate that coronary blood flow is compromised. Now, to determine how to read an ST elevation or an ST depression on an EKG strip, all you need to look at is the underlying rhythm. So this line right here, if your ST segment is higher than your underlying rhythm or lower than your underlying rhythm, there might be ST elevation or ST depression. All right, so you've made it to the end of this long video. Thank you for bearing with me. I know this was a lot of information, but this will absolutely help you in analyzing the ECG strips that we have for your activity. These are the references that I used in making this PowerPoint. If any of you are interested in continue learning about EKGs, or if you guys want extra work with EKGs, Rapid Interpretation of EKGs is an amazing resource in reading EKGs, and an ECG Workout has a bunch of practice strips that can help you practice reading and analyzing EKGs.